I am very honored and privileged to be part of this lovely international pediatric neurosurgery course, which Professor Salman Sharif, as well as yourself, have organized. And it gives me actually a feeling of some pride that I'm actually closing the course today. And yes, the topic that I want to talk about is, by the way, is my screen sharing?
Yes, but
okay.
But you can actually do the PowerPoint presentation mode, so we can see the whole. Yes,
that's
right.
Can you
That's
see?
it.
Perfect.
Yes.
Okay. So as Adrian said, for many years now, nearly 20 years, I've been battling with this thought that a Chiari malformation shouldn't really be called Chiari malformation, should be called Chiari deformations, and that it's something that probably requires a fresh look at, and we've been doing that here in Birmingham. My predecessors opened the way for me to advance the thoughts on this. So what I'm going to talk to you about today is the pediatric management of Chiari malformations, but offer you a new algorithm and a way for you to consider as an addition to the armamentarium on management of Chiari. So you can see we work in a very old hospital. It's got a imposing sort of historical facade. I don't know if many of you have been to Birmingham. Salman, you definitely have been to Birmingham, isn't it?
Yeah.
So you would have seen this hospital. We moved here about 25, 30 years ago. We used to be in the sort of mixed hospital before. To be honest, I have no conflict of interest to declare. And what I want to do today is to talk on a number of things. First, I wanted to spend some time to talk about the concepts of what is a malformation, what is a deformation, because we use this word malformation with some triviality, and it shouldn't be. We should also talk about, tonsillar hernia or hindbrain hernia, and what actually the physics of a hernia progression are, and then the basis for rational treatment of a hernia anywhere in the body, but specifically in the special circumstances of a hernia in the foramen magnum, and then the concept of what maintains a hernia or makes a hernia worse, which is called supratentorial crowding in the presence of a small posterior fossa, and then we'll move on to look at what actually causes a Chiari, because I don't believe a Chiari is the primary disease. And what causes Syringomyelia, because many of this, the children or adults that present with Chiari Syringomyelia, they have a driving force or causation that leads the condition to progressively get worse. And then we'll look at, in terms of the Chiari itself, what is the natural history, how does it progress, when do we treat it, what are the treatment modalities, and I will also review some of the publications, and time permitting, I'll give some case examples as well. So starting with the definition, of course, the definitions have changed over time as well, but I think the well-accepted definition now is the one given by Barkovich in 1986, that the limit of 5 millimeters of tonsillar descent below the foramen magnum is considered as a Chiari malformation, as we call it. And you can see on this image that there are various types of hindbrain hernia. So the progression means that there is a further descent of the tonsillar hernia. And as the descent happens, you can see that it then starts distorting the cervicomedullary junction and starts changing the shape of the cerebellum as well, which normally is a C-shaped. And by the time you get extensive herniation, the cerebellum looks standing up. And the other things that you can see in this picture is that the tent, which has got a fairly sort of a normal angle here, it becomes really an acute angle, as you can see, and it just gets more and more angles, and the torcular sometimes in these patients is at the foramen magnum. So all of this must be taken into consideration when planning surgery for a hindbrain hernia. So first I'll briefly talk about the difference between malformations and deformations. And by definition, a congenital malformation is a structural or functional anomaly that occurs during intrauterine life. These conditions develop prenatally, may be identified before, at birth, or later in life, but they don't grow or progress in size as a tumor would. And deformations, on the other hand, are the action or process of deforming or distorting a structure. And the shape either flattens or elongates. And this deformation is caused by external forces over a period of time. And deformation can be progressive, it can remain stable, or even regress as the forces that act on the structure change. And that's what we see in the hindbrain hernia. And the natural history of the condition quite well defines that hindbrain hernias can spontaneously regress, progress, or remain stable for long periods of time. So then the other topic that I really wanted to talk to you about was hernia. So we talk about hindbrain hernia, but do we understand what the word hernia means? So all of us have gone through training. We've all done the FRCS. Some of us have done the FRCS in general surgery and then went on to do neurosurgery. And we all learned that the hernia, which we have treated either inguinal, abdominal, any part of the body to a muscle, is that there is a displacement of an organ through a opening, and that could be opening in through the muscle. So there is a cavity, and the two compartments are connected by an opening. So, for example, the intestine would, in the abdominal cavity, would herniate through a weak point in the inguinal orifice into the groin, and that would be what we would call an inguinal hernia. Or the intestine at the weak point in the abdominal wall would herniate like an umbilical hernia or a muscular hernia. And equally, what happens here is that the contents of the skull, the cerebellar tonsils, will herniate through the foramen magnum, and that would be a hindbrain hernia. In all of these conditions, there is an increase in pressure in one compartment that drives the herniation. And the greater the pressure, the greater the herniation. And the herniation is really defined by the orifice. So the orifice has to be incompetent to allow the herniation. And that means that in the case of a hindbrain hernia, the foramen magnum actually has to be incompetent. And the treatment aims to reduce the pressure in the compartment that is causing the herniation, tighten the orifice to reduce the hernia and prevent the recurrence. But what we actually are doing is the opposite, isn't it? We are increasing the size of the orifice, and that really, in terms of physically or in terms of the physics of a hernia, would be counterproductive. Because if you increase the hernial orifice, you're likely to increase the amount of herniation from one compartment to another. So I think that's the point that we must keep in mind, that if we are treating a hernia, even if it is in the foramen magnum, increasing the orifice is likely to provide the opportunity for further herniation of the contents of one compartment, particularly if they have increased pressure in that compartment. So a little bit about Chiari malformations. So we know from experimental models that Padilla and Padilla carried out quite many years ago that Chiari malformation can be recreated in vitro by genetic manipulation. And it's a primary para-axial mesodermal insufficiency occurring at the closure of the neural folds, and that is well known. Now, the primary factor for the formation of hindbrain hernia is that the foot-occipital somite does not develop properly, and you get a small posterior fossum. Sometimes you get a small clivus. So the volume of the skull in the posterior fossa is smaller. So the contents of the skull have to herniate because there's not enough space. And the main objective of the surgical treatment is to restore the normal CSF dynamics at the craniovertebral junction. So that's been well accepted. So, and what is the natural history of Chiari? Now, I'm simply talking here about Chiari 1 because that is one that we can assess better. So you can see the asymptomatic Chiari 1 type 1 malformations. I think the largest radiological study that's been carried out was at Johns Hopkins by Benjamin Carson and Jeffrey Meadows. This was a study that was published in 1992, 22,591 patients at consecutive MRI imaging. 175 of those patients were found to have Chiari 1 malformation, extending more than 5 millimeters below the foramen magnum, and 14%, which is about 25 patients, had what we would call an associated, a Chiari, which was clinically asymptomatic. So that's 14%. Now, when they looked in detail, what they found is that the presence of Syringomyelia or osseous anomalies were present only in those patients that had a symptomatic hernia. So it is not everybody that presents with tonsillar hernia. And what they found as well is that the presence of Syringomyelia was associated with a tonsillar hernia of about 11.4 millimeters. Now, when I looked carefully at the 25 patients and 21 with a symptomatic Chiari malformation, only 6 were children under the age of 18. And they had a number of different issues like congenital hypothyroidism, motor delay, precocious puberty, headaches and sinusitis, and I think one was done for research purposes. So of these 6 children, I think you can make very little in terms of deductions. But one thing that was clear from the study was that there is a relationship between the size of the cisterna magna and the herniation. So if the hernia is up to 10 centimeters, the cisterna magna is still okay. Once the hernia is more than 10 millimeters, it goes to 10 to 15 millimeters, then the cisterna magna becomes reduced and ultimately becomes absent. Sorry, I think my screen is frozen. Okay. The second study that was done was the one done by Ezio De Rocco, Professor De Rocco and his colleagues in Rome. That study was a smaller study, 22 patients. But what they found is that in 50% of these Chiaris, they were incidental, so they were not symptomatic. But the Chiaris had a clinical worsening in 22% of cases. So 1 in 5 children had a progression, and 14% actually progressed to surgery. So clearly there's a group of patients that progress, but then there is a significant group between half to 3/4 of patients who are asymptomatic. And then when we look at the radiological progression, so this is again in natural history. So what does radiology tell us? So, well, there are 2 studies that were carried out in 2011 to both of a significant number of patients, 124, 147. The mean follow-up was short, 2.8 to 3.8, so less than 5 years. And both of them declared the progression of somewhere between 3 to under 10%. There were no cases of regression, and the patients who had no change were quite a lot, between 90 to 97%. Then more recent follow-ups were longer, so more than 5 years, 5.8 and 5.2 years. One again from Professor Concesio De Rocco's team in 2008, and our own study in Birmingham in 2013. Less number of patients, but clearly the follow-up was significant because we saw significantly higher numbers of progression between 10 to 14%, but also regressions, so spontaneous regression between 3 to 5%, and patients with no change somewhere between 72 to 87%. So what is the consensus in terms of progression of a hindbrain hernia in children? What we can tell is that in the short follow-up, less than 5 years, usually radiological progression is rare, and there is little clinical progression. If you look at medium follow-up, then you can start seeing progression that becomes more evident, but also in some cases spontaneous regression. So you must keep that in mind, that not all children need to be treated. But there is also a subset of children under 2 years that can progress rapidly. That means under 2 years of disease onset rather than 2 years of age. And that subgroup can lead to obstruction of CSF at craniocervical junction more rapidly, development of syringomyelia, and they may need surgery more quickly. So looking at the pattern of progression and severity of Chiari, we know this information now, that at the mean of 5 years of follow-up, something like 3 to 5% will regress spontaneously, 14 to 50% can be asymptomatic, and between 10 to 14% will progress radiologically. But do they progress equally? And I think here we have to develop a clear concept that not all Chiaris are equal. And we have tried to separate them as simple Chiaris and complex Chiaris. That means a patient who has tonsillar hernia with syringomyelia, with one or more features like ventriculomegaly, craniosynostosis, loss of CSF at the craniocervical junction anomalies, syringomyelia, or scoliosis. Those patients have to be classified as complex patients rather than simple, and their management clearly would have to be more careful and would involve more investigations than a simple Chiari. And what would be the mechanism of progression? So that, again, requires some detail, which I won't be able to give you today, but there is several theories on the development of syringomyelia within Chiari Malformations. Bernard Williams, who worked at the Children's Hospital in Birmingham, postulated the craniospinal pressure dissociation. Gardner and others suggested CSF pulsations also as a pathological drive. And so all of that plays into the pathology. And when does a Chiari become a surgical disease? So I think there is some consensus to this, and the ISPN carried out an international survey that indicated the majority of surgeons consider tonsillar descent of 12 millimeters with loss of CSF at craniocervical junction and appearance of a syrinx parameters they would consider that would require surgery then. And can any Chiari be treated by foramen magnum decompression? So I think that is where the separation between simple and complex Chiaris become important. Because complex Chiaris won't just respond to a simple foramen magnum decompression. And you need to find the root cause of what's causing the Chiari in syringomyelia. And careful planning and investigations would be warranted. And that is why in Birmingham, we've decided to look at developing an algorithm to assist us in management of complex Chiari patients. So just to summarize the introduction, I would say that I think Chiari malformation should be termed deformations because of the way that the hindbrain hernias behave. They're definitely not a tumor, and they seem to be, in some cases, progressive. And we believe that the causation of a hindbrain herniation or Chiari malformation, deformation, whatever we call it, is because there is increased pressure in the skull vault. And that means that there is supratentorial crowding. So the brain above the tentorium, either the ventricles or the brain itself, has a smaller space. So there is a craniocephalic mismatch, which is driving crowding into an already small posterior fossa because of the occipital somatic regression. And that then leads to herniation of the contents of the posterior fossa and Chiari, and then subsequently syringomyelia. And now in this context, we also have to consider ventriculomegaly, which can either be secondary or could be causative of the increase in pressure. Now, we also know that the hindbrain hernia associations are very clear. So if you look in the literature, it is going to be ventriculomegaly, craniosynostosis, basilar invagination, craniocervical instability, and scoliosis. And the same associations of a Chiari are also present in syringomyelia: ventriculomegaly, craniosynostosis, basilar invagination, scoliosis, and craniocervical instability. And in addition to that, we also know that syringomyelia can be present without the Chiari, but with the tethered cord or spinal lipoma or split cord malformations where syringomyelia may be present. So we have to consider those associations when managing Chiari. And the other study that has not been well reviewed or investigated is that in Chiari 1 malformations, there's a clear relationship now with endocrine insufficiency. And we did our own study here in Birmingham, which identified quite significant findings. So 40% of the patients with Chiari malformation had growth hormone deficiency on treatment. 15% had growth hormone deficiency and short stature, which is what we call the idiopathic short stature. 20% had short stature, but no growth hormone deficiency. And more than 20% were obese, but that again is related to the epidemiology of children in the UK. But if we flipped it around and looked at children with growth hormone deficiency and how many of those children had Chiari malformations, only 1.2% of the children at Chiari malformation, suggesting that it's not the growth hormone deficiency that's driving Chiari malformations, but the other way around. So that definitely deserves a greater study. And it's not just growth hormone deficiency, although we highlighted that here, but thyroid deficiency and a number of other hormones as well. So when we look at ventriculomegaly, then again, what happens first? Does ventriculomegaly cause a Chiari? Does it have supratentorial piston drive pressure that drives the contents of the posterior fossa further down? So that certainly is one of the thoughts on this, that it acts as a piston drive and pushes everything down, obliterates the cisternal CSF at the craniocervical junction, causes loss of buoyancy, further descent of the tonsils, and impaction. So that's one possibility. But also you could consider that the Chiari would block the foramen of Luschka and the foramen of Magendie, and thereby causing an increase in ventricular size. And so I think that the two is like catch-22. Once one develops, the other gets worse. And once the other gets worse, then the hydrocephalus will worsen further because the exit pathways for CSF into the arachnoid cisterns is obliterated further. So I think we need to keep that in mind when treating hydrocephalus associated with Chiari malformations. And in this regard, a number of my colleagues around the world have already been working on this, and they've published the experience of endoscopic third ventriculostomies in the management of Chiari and related hydrocephalus, like again, the Consensi de Rocco's team in Rome, my friend Conor Malucci in Liverpool, and they both reported that if you do an ETV in a child with Chiari malformation, in fact, the Liverpool study was included adults as well, 94% remain shunt-free, and 83% of children with the syrinx had improvement of resolution of the syrinx following an ETV. So endoscopic third ventriculostomy is a well-accepted treatment now for children who have a Chiari malformation and ventriculomegaly, and there is a consensus that we should treat the ventriculomegaly before treating the Chiari malformation. Further, this is a larger study from China. We also reported 80% success rate in seeing hindbrain hernia regression following endoscopy. So we looked at our own data in Birmingham, again, to see what was the effect of third ventriculostomy in children with Chiari 1 malformations. And we looked at long-term outcomes in our institution, and that means at least 10 years. And what we found is essentially, when we look at here, 130 patients who underwent 139 ETVs, older than 1 year of age, and it was either the etiology, the primary etiology in this case is mostly aqueductal stenosis and tumor, or primary obstructive hydrocephalus, but you can see here that there were 10 children. Now the number is of course increased. This study was done several years ago, but of the 7% of the children who underwent ETV for Chiari in spina bifida, 9 out of 10, that's 90%, had a successful outcome. And this included patients with achondroplasia, craniosynostosis, spina bifida, isolated Chiari, and of the isolated Chiari, for example, 4 patients had Syringomyelia in addition to ventriculomegaly, and 90% regression with deflation of the Syringomyelia in all cases. So when we look at the factors associated with Syringomyelia in children with hindbrain hernia, because not all children with Chiari will develop a syrinx, but there is a subgroup. And what we identified is that when you look at the appearance of the Chiari, it's very different in children who have Syringomyelia. And they often have this skull base, short stubby clivus, a long elongated dolichoid dens, and a standing up cerebellum. So a lot of features, peg-like tonsils, and all of this seem to be forming a pattern of radiological appearances that we commonly see in patients that we term as complex Chiaris. And you can see here the standing up cerebellum, venous hypertension, the very sort of low angle of the tent near pretty much the foramen magnum, So in those patients, you hardly have a posterior fossa, and the contents of the posterior fossa by force then herniate through a very wide foramen magnum. So that is the incompetent or hernial orifice. And this, of course, all of you know, is a normal appearance, a C-shaped cerebellum, which I call seating cerebellum because it's sitting on the occipital bone, which is curved at the bottom and forms the opistheon of the foramen magnum. Lots of CSF around. And then when you look at an herniation, you find that there is a descent of the tent, the small posterior fossa, the cerebellum is pushed forward and becomes standing, the hernia, blockage of the CSF spaces, opistheon is no longer curved, but is straight. So it's like a slide rather than a chair. So the cerebellum can no longer sit in a chair, it's sliding in a slide. That's the way to kind of explain this. And then Menezes pointed out that in these children, about 50% have craniocervical junction abnormalities. You can see here platybasia. The C1 is nearly at McRae's line, suggesting a degree of basilar invagination. And they, of course, although the Chiari is not very impressive, they develop syringomyelia as a result of obstruction of CSF flow. So what we started looking at is that there are a number of conditions associated with the Chiari and syringomyelia. So the first one is that the vast majority of cases of syringomyelia are associated with Chiari, and they have craniocephalic mismatch. They can have craniocervical compression. They can have craniospinal pressure differential, and finally restriction of spinal cord ascent and robencephalon rotation. So these were the conditions that we thought are associated with syringomyelia. More than 90% of cases of syringomyelia have a hindbrain hernia. There is craniocephalic mismatch, often either caused by craniosynostosis, involving the skull, like beta thalassemia, sickle cell disease, osteopetrosis, over drainage of CSF, for example, arachnoid cysts that had been undergone cystoperitoneal shunts, even over draining VP shunts under the age of 3 years, vascular conditions. So all of those can lead to syringomyelia. Craniocervical compression, definitely. Craniospinal pressure differential, we all know that in cases where there's over drainage of CSF, that you get a hindbrain hernia, and then you develop spinal drainage problems with increase in spinal pressure. And then restriction of spinal cord ascent, which is caused by tethered cord, spinal lipomas, and so on and so forth. So there are a number of conditions. And we can also identify the likelihood of a syringomyelia, for example, by looking at the craniometric measurements in the posterior fossa, which we did here in Birmingham. And you can see the statistically significant variables, like small posterior fossa, the larger sagittal diameter of the foramen magnum, then the presence of obtuse posterior fossa angle, or the Bogart's angle, which is the line between the clivus and the opistheon. So all of those were reliable indicators that this child could develop syringomyelia. But the loss of CSF at the foramen magnum was the biggest statistically significant finding. And our statistician then put all this together and predicted that a child who has 100 months of age, clivus angle of less than 0.8, is the likely candidate to develop a syrinx. So there are some predictors. And therefore, we can then design a pathophysiology concept that says that both the Chiari and syrinx formation have a strong statistical relationship to small posterior fossa. That in children who have a Chiari and syrinx formation, that there is a likelihood that there is a supratentorial crowding, which is continuously increasing the compartmental pressure and driving herniation down, which is progressive, and then leads to development of syringomyelia. Now, if I show you a picture like this is multiple sutural craniosynostosis. You can see that there is no doubt in your mind that a child whose brain is trying to push out by eroding the skull and causing this copper beaten or honeycombed appearance of the skull has raised intracranial pressure and severe craniocephalic mismatch. And you would understand that in a patient like this, who has a Chiari and Syringomyelia, that increasing the size of the skull is critically important. And you would agree that expansion of the skull is the treatment of the hindbrain hernia in Syringomyelia. Same thing here. This is a child with clear shadow deformity, MRI done at 2 months of age, severe pansynostosis, brachyutericephaly, small posterior fossa. You can see the posterior fossa is nearly non-existent. The torcular is in the opistheon. What are you going to do by increasing the size of the foramen magnum? This child has also got ventriculomegaly and hindbrain hernia. In those cases, your primary concern is to increase the size of the skull, and that would improve the craniocephalic mismatch and lead to improvement. And again, I talked about the progressive deformation of the posterior fossa, cervicomedullary junction, how it affects the brainstem, and so on and so forth. And again, I'm reviewing the MRI appearances of a complex Chiari, where you not only get this peg-like tonsils and a small posterior fossa, but you get this venous hypertension, cervicomedullary kink, and so on and so forth. So all of those features have to be kept in mind when you think about tentorial crowding. And how does tentorial crowding play a role? So you can see this pictorial diagrammatic representation. In a normal case, if you run a line between the posterior clinoid and the inion, 1/3 of the cerebellum is above that line. In a Chiari, you can see a small posterior fossa. You can see the angle of the tentorium is so different, and that there's hardly any cerebellum above that line. Your inion is no longer in a straight line like that. It's lying halfway down. And what has happened now, you can see the occipital lobe lying above the cerebellum normally. That is no longer the case. It's now lying below, and there is a significant content of the cerebellum and occipital lobe that is no longer where it should be. So at least a part of the posterior fossa is now occupied by the occipital lobe, which pushes the cerebellum forwards. And occipital lobe lying behind the cerebellum is prima qua non facie confirmation that this patient has got supratentorial crowding. And therefore, you have to think, how am I going to improve the situation and reduce the supratentorial crowding, which is reducing the posterior fossa volume? And the solution to that, of course, is to increase the size of the skull by a calvarial augmentation. And that is what the vast majority of children with craniosynostosis now, at least in the last 15 years or so around the world, have been undergoing. After we published our procedure of posterior calvarial augmentation. And we started doing this procedure in 2003. So it's been 17 years that we've been doing this. And what it aims to do is to reverse this problem of supratentorial crowding. Now, when we looked at the foramen magnum, because the question here is the foramen magnum small, so small that is tightening the CSF flow and causing the syringomyelia, or is the foramen magnum so large that is contributing to the herniation? And that is exactly what we found. We did a study of children, normal Asian sex-matched patients with Chiari 1 and Chiari 2, and what we discovered is that in Chiari 1 and Chiari 2, the foramen magnum dimensions, both sagittal, transverse, and surface area, are much greater in Chiari 1 than in children with the normal, who had an MRI scan for other conditions, but Chiari and Chiari 2. And of course, we talked about the association. So we can summarize them and say that there are supratentorial causes, posterior fossa causes, foramen magnum, and spinal. And in supratentorial, we put hydrocephalus, craniosynostosis, and functional aqueductal stenosis as the common causes. In the posterior fossa, of course, the small surface area, the steep angle tentorium, all of that we just discussed lies in there. And then in foramen magnum, the mesodermal abnormalities identified by Menezes and others, platybasia, basilar invagination, foramen magnum incompetence, atlas assimilation, clival anomalies, all of those play a role. And then in the spine, things like dolichoid dens, ossodontoidium, atlantoaxial instability, spinal cord compression, fusion segmentation anomalies, searing, scoliosis, and of course, the dysgraphic conditions as well. So I will just point out again that herniation requires an increase in intracranial contents, a small relative cranium in the presence of an incompetent hernial orifice. And our treatment of that hernia should be to reverse, first of all, to reduce the intracranial contents by reducing the craniocephalic mismatch. We can't do much about the small posterior fossa because even if you try to increase the posterior fossa, that increase is not enough to reverse the condition adequately. And then the treatment of how to reduce the incompetent hernia orifice. And we know from our data that syringomyelia is often the effect of hernia strangulation when too much of the cerebellum has descended down, so there's no more CSF flow. And we presented some of our data in terms of craniovertebral malformations in the children leading to Chiari in Syringomyelia. And again, the occipital assimilation, occipital fusion with the atlas and the homeotic transformations were the significant causations of the bony lesions leading to that. If you want to remember this, of course, I don't want to go into too much detail, but if you want to remember this, you just have to remember that it's the fourth occipital somite that leads to failure of proper pro-atlas development, and all of the abnormalities related to Chiari fall in this group here. So that's the thing we're interested in, nothing else. The atlas assimilation is well known to most of you, leads to assimilation of the atlas, fusion, so there's no movement between the C0 and C1. So all of the movement is forced upon C1, C2, leading to C1, C2 instability, and also C2, C3 are also fused. So you can't move C2, C3, you can't move C0, C1. So all the movement occurs at C1, C2, leading to C1, C2 instability, and that then leads to hindbrain hernia and syringomyelia. The multiple classifications, which I won't go into, you know that the diagnosis of atlantoaxial instability requires dynamic views. Now, of course, you can do CT dynamic views. And the diagnosis actually, you know, you must consider that it could be horizontal, the subluxation, it could be vertical, it could be lateral or rotatory. So often we think of subluxation as just horizontal C1, C2, but you must consider that once there is instability, that vertical subluxation can also occur. And this is well described by those who take an interest in this area, like Professor Goel, that atlantoaxial dislocation or instability is the primary cause of all types of basilar invagination, irrespective of whether it's demonstrated or not on dynamic imaging, because often what happens is initially you can measure the herniation. So this is a normal situation. For example, the atlantodense interval is less than 5 millimeters and the posterior atlantodense interval is 14 to 21. But when you start seeing, and of course this is the abnormal situation, there is an increase in atlantodense interval. The ring is the arch of C1, and then when you have basilar invagination, actually C2 is moving up towards the posterior arch of C1, and actually the dimensions are no longer as wide because the body or the base of the odontoid process is wider. So you don't actually see that radiologically, but in fact, the herniation has got worse because now it's not horizontal, it is vertical. So that's the sort of things to keep in mind when you think about herniation, that it's not a static process, that horizontal subluxations will ultimately become vertical because the lateral masses of C1 will separate from each other, and the angle subtended between the C0, C1 joint with the base of the odontoid will change from 124 degrees to 135 degrees and so on, as the lateral masses fall outwards. As they fall outwards, the body of C2 will move upwards in between the lateral masses of C1. And the process can be represented diagrammatically. You can see here that the lateral muscles, which should be lying horizontally above the lateral muscle C2, start angling, and this angle worsens to the point that the lateral muscles C1 are then lying on the sides of the lateral muscles of C2 and ventrally. They're lying in front and to the side. And C2 then rises up and crosses the foramen magnum. And the treatment of that, of course, means you have to reverse it by pulling C2 down again and fusing C1, C2, or with the occiput. So you can see here on the CT scan, this is the lateral muscle C1, this is the lateral muscle C2. The C1 is lying ventrally in front and laterally, and that means that there is absolutely no way to stop the skull from descending down with C1 onto the spine. These are other images of basilar invagination. Group A is when the tip of the odontoid has crossed McRae's line and is inside the skull. Group B is when the tip of the odontoid has crossed the Chamberlain's line, which is the line between the hard palate and the opistheon, but is below McRae's line. So those group A and group B have remained the standard classification of basilar invagination, and that can tell us the severity of the condition, but in both cases, treatment is usually warranted. And you can see here what is happening, a simulation of the atlas. The tip of the odontoid is well inside the skull, causing compression at the craniocervical junction, and that compression stops CSF flow, and you'll end up having syringomyelia. And there is usually a Chiari as well. Because of the platybasia, the small skull volume, and of course the contents of the posterior fossa will herniate down. So this is all hand in hand, and there are also various classifications about the facets and the function of the facets in maintaining stability, and how the facets, once they become unstable, the situation can only get worse. So Professor Goel has classified the facet instability as anterior, central, and posterior. In any case, what we're interested in is what does it do to the cervicomedullary junction, and you can see here the severe compression and the development, although in this picture we can't see the syringomyelia. Usually there's an associated syrinx as well, and the compression of that is clearly important. So I'll show you a picture, a case that we had, a child with persistent headaches, snoring, apneas. This child actually had Crouzon syndrome, and I had carried out the frontoorbital advancement and calvary augmentation many years previously. And then she presented with this craniocervical instability. I was quite shocked to see this picture. The child had a Chiari, had become pretty much myelopathic, and you can see it on the skull, the previous sort of Craniosynostosis, evidence of previous surgery. And you can see the position of the lateral muscle C1 lying in front of lateral muscle C2, severe basilar invagination, platybasia, and that is the lateral muscle C1 lying quite laterally in relation to C2 and ventrally as well. So what we did, as we do in normal, in these sort of situations, is to, with great degree of difficulty, put C1 screws and C2 screws. In this case, we put occipital screws as well, because it was very difficult to distract them. And then you can see before the surgery was a type A basilar invagination, and after the surgery, the distraction of C2 down away from the foramen magnum. And then this is the pre-op picture and the post-op picture. Fixation and the regression came up with is this algorithm that if you have ventriculomegaly, you're going to get raised intracranial pressure, supratentorial crowding, and craniocephalic mismatch. If you have craniosynostosis, the same thing is going to happen. And if you have a basilar invagination and craniocervical junction anomalies, you're going to have a small posterior fossa craniocervical mismatch. Now, with supratentorial crowding, you get a downward push. With the craniocephalic mismatch, you get stretching of the tissues through the foramen magnum, and they lead to formation of a Chiari. And the Chiari will obstruct CSF flow and cause a syrinx. of course, in those conditions with split core malformations, lipomas, dysgraphic conditions, there will be scoliosis, tethered cord, a caudal pull where the spinal cord is being pushed down, and that will then lead to a syringomyelia. And the surgical approach for this should be tailored to either increasing, so if you do a craniovertebral decompression of the posterior fossa, you have to create adequate space. And it has been emphasized that if you do a suboccipital craniectomy, you should make it small enough to avoid downward migration of the hindbrain to the craniectomy, because you're just increasing the hernial orifice, and that will lead to a slump of the hindbrain, and that multiple studies have demonstrated this in the past. And what we want to achieve really is to get the CSF flow signal through the craniocervical junction, reconstruction of the cisterna magnum, and upward migration of the cerebellum, improve the syrinx to cord ratios, and as you know, ideally you should get the regression of the hindbrain hernia as well. But the treatment of Chiari malformations has been singular, and by that I mean a craniovertebral decompression. And the craniovertebral decompression can be done in a number of ways, either by opening the dura in the arachnoid, opening the dura with arachnoid and then leaving the dura open, or doing an expansion duroplasty, or going further and doing a tonsillar resection with the duroplasty, or then taking the posterior C1, posterior C2. So it's on and on. There are 10 different ways of doing this. But what we know is that the complications of foramen magnum decompression have all to do with opening the dura to carry out too large a posterior fossa decompression or too extensive resection of the posterior arches C1 and C2. So if we can avoid that and still achieve those objectives, then we should be a lot better. These are other complications of the dural opening, pseudomeningocele in something like 40% of cases, posterior fossa chemical meningitis, arachnoid adhesions later on. And this has been well demonstrated by those that carry out this procedure in large numbers, like George Clay-Clamp. He analyzed these patients, identified that for symptomatic patients, not only craniectomies, but C1 laminectomies, arachnoid dissections, duroplasty, these patients come back to them with more problems. And the success rate for revisions is limited. So the rate of long-term success for foramen magnum revisions was limited to 2/3 for 5 years. So in those units where large numbers of operations are carried out, you can see also more recognizable complication of this procedure, including things that weren't there before, like craniocervical instability, hydrocephalus, bleeding, and so on. So my colleagues from Oxford published this paper on recurrent subdural hygromas after foramen magnum decompressions. Another study from my colleagues from Liverpool raised concerns about raised intracranial pressure and hydrocephalus after decompression for Chiari 1 malformations. So they identified in their series I think about 20% of patients had developed iatrogenic hydrocephalus and required shunting when they did not have hydrocephalus preoperatively, when they had carried out a Chiari malformation, a foramen magnum decompression. A further study from Ireland, from my friends John Cadd, Derek Crimmins, and David Alcott, and others, also indicated that in their hands, they thought that foramen magnum decompression should not be underestimated. It's a formidable procedure because if the Chiaris are complex, there is a lot of complications. And they also reported complications in 1/3 of the patients. 18.5% of their patients developed hydrocephalus requiring shunting. Others had subdural collections, like the team from Oxford reported. So they also concluded that the risk of developing postoperative hydrocephalus requiring permanent shunting is relatively high, and ICP monitoring should be carried out in children before doing foramen magnum decompression. And then finally, papers started coming out about the comparison of doing a Foramen Magnum with duroplasty or without duroplasty. And they all reported a greater risk for CSF-related complications if you carried out a decompression with duroplasty. But there was a lower risk of reoperation than if you just did a decompression without duroplasty. In 2009, we then published our technique of posterior clavicular vault expansion using distraction osteogenesis. We had started doing this since 2003 in the form of a posterior clavicular augmentation and then distraction from 2006. This is a picture from the paper that shows our initial distractors and the distraction of the skull, and then a gradual distraction of 1 millimeter a day over a period of 3 weeks to get a 21 millimeter distraction. We've then further published in child's nervous system evidence that the hindbrain hernia and Syringomyelia can improve with this technique. Others also published that in Craniosynostosis, posterior clavicular augmentation was helpful. Further reports from the States, from Professor Ocherman and Richard Allen Bogan, that a suboccipital decompression is not necessary if you treat the Chiari malformation with a standard procedure for syndromic craniosynostosis, which is a posterior clavicular augmentation. So a strategy of initial cranial vault release followed by watchful waiting and radiological surveillance is proposed. European colleagues started using our technique developed in Birmingham, posterior cranial vault distraction, and Nina Salakorpi and Willy Serlo published their results. Then further studies from Eric Arnaud in Paris with Federico De Rocco also concluded that posterior cranial vault distraction is an efficacious technique to enlarge the posterior skull vault and treat increased ICP, and that it appears to be efficacious in treating hindbrain hernia-related symptoms. And so what do all of these papers try to show? Basically, you got a normal skull and a syndromic skull. And what we're trying to do is basically increase the part of the skull which is causing the mismatch. And once we do that, what we expect is that the raising cranial pressure present in syndromic craniosynostosis will reduce, and that will create enough adequate space to allow the reduction in the craniocephalic mismatch. So at Birmingham, from 2003 to 2006, we started doing a fixed clavicular augmentation, and then we added the posterior distraction osteogenesis from 2006 for craniosynostosis patients, and that is still our technique. So what we do is, this is a diagrammatic representation. We make a cut, and then we push that back and fix it. Sorry, just want to make sure that, okay. And then put in some plates. Sorry, I think my screen is frozen. Okay. And this is the appearance on the skull. This is an intraoperative picture. You can see that there is a small island of bone kept for the shunt, and the bone is cut. You can see the posterior parietal bone, the parietal plates, and then at the middle part is the bone keel over the posterior sagittal sinus, which must be removed to reduce the intracranial venous hypertension. The bones are then put back. This is the reflected scalp in the occipital region. That's the ears there. We can barrel stave the bones in very young children. And then we use resolvable plates. You can see the resolvable plates there. And that is the fixation. The x-rays will look like that. That was the fixed technique. I'm just gonna, for brevity of time, I'm gonna jump the results now and just show you, these are just the results. And what I want to show you is technique in craniosynostosis, which essentially is where we distract a fixed piece of bone, which is not lifted off the dura, and we basically distract 1 millimeter a day for 21 days giving 21 millimeters of distraction. And this allows much better results in terms of failure of scalp breakdown and bone fusion in the gap. You can see here, this is a preoperative image where there's a very small posterior fossa. The cut is done just behind the coronal suture and goes across below the lambdoid suture, about 1 centimeter or 2 below the foramen magnum. And we angle it about 5 degrees upwards. And then this is the postoperative appearance, and you can see the difference between the flat skull and the round skull postoperatively. So that is increase in the dimensions of the skull with very nice fusion, which allows for adequate space, and then regression of the hindbrain hernia and the deflation of the syrinx. This is x-rays at 1 week, 3 weeks, and 15 weeks. And you can see that the translucency becomes less over a period of time. And as we distract, new bone forms in the gap. That's why we call it distraction osteogenesis. And the shape of the child with craniosynostosis improves sequentially from brachyturicephaly and gradual change in the shape. And you can see that there is also improvement in the frontal part because on Newton's law, you get equal and opposing forces. So the forehead improves as well. We then recently published our data of posterior cavalarial distraction for children with complex craniosynostosis, Chiari Malformations, and Syringomyelia, 10-year experience. And that shows that in children with craniosynostosis who had Chiari and Syringomyelia, that there was a significant reduction in both. With 3 out of 4 patients with the syrinx having a syrinx improved or completely deflated with regression of the hindbrain hernia in all cases. This is a child with a lipomyelomeningocele who presented with a severe hollow cord syrinx and a tethered cord. And following surgery for the tethered cord, you can see the deflation of the syrinx. So this is the other part of the algorithm where some children who won't have a hindbrain hernia, but will have a massive syrinx affecting the whole of the cord because of a tethered cord, and untethering of the spinal cord results in improvement of the syrinx. So this is the other part of the algorithm. So again, this is just a summary, and just to show you that ventriculomegaly, basilar invagination, craniosynostosis, and dystrophic conditions all lead to either Chiari or Chiari and Syringomyelia. And the treatment is basically to reverse the algorithm and say that in those patients who have ventriculomegaly, we recommend an ETV in the first instance and then monitor. If they have craniosynostosis, a posterior cavalarial augmentation is preferred to foramen magnum decompression. If they have scoliosis, do a posterior cavalarial augmentation and then review, because 1/3 of our patients now have not required scoliosis correction anymore. Basilar invagination in craniocervical junction, either stable or unstable, carry out the fixation and reduction of invagination, and then assess and see. And finally, those with lipomas definitely carry out untethering, and that will often result in improvement of the syrinx. So what I'm going to do is probably stop here because we're probably running short of time. I can discuss the cases if you want afterwards, or I can continue to discuss the cases now, but I'll put it back to you, Adrian. Thank you.
Well, I think this is a great eye-opening for many. Every single time I hear this lecture from you, it reminds me of a case that I did many, many years ago. This was a child who had hydrocephalus. It was a shunted hydrocephalus. And he had a borderline Chiari. And the child actually complained a lot about suboccipital headaches. So naturally, at that time, I think the trend, this is 15 years ago, the trend was, okay, so we should do a foraminal decompression, right? And without thinking too much about it, I went about the case and removed the rim of the foramen magnum and C1. and the child was extubated and wasn't recovering. He was doing fine. So I went to take a cup of coffee, and 15 minutes later, I heard that there was this call that the child was coding, and we could not reverse, and the child eventually died. Now, because this question might be in many of you, we had revised the shunt previous to the foraminal decompression. But when I went back and saw the films of this child, I realized that he had no CSF either in the convexities or in the basal cisterns, and that what I had done was that somehow the plug created by the tonsils, whenever I opened the foramen, what I did was just open the gate for the posterior fossa contents to herniate at the next cycle of intracranial pressure. So that brought me to a lot of thinking. And for many years, what we did was spiralization of the parietal plates. But of course, yours is a much more elegant solution. How many more cases do you have? We cannot hear you. Guirish, you're muted.
Sorry about that. Can you hear me now?
Yes.
Oh, perfect. Yeah. My apologies, because this thing keeps disappearing on me. Oh, there it is. Okay. Yeah, you can hear me now. So I wanted to show you a particular case that we had, and this might actually help show the problem. So in 2014, a child presented with the holocaust syrinx. You can see a tight foramen magnum here, and the syrinx was somewhere towards the mid-thoracic spine. And we discussed this in our multidisciplinary meeting, and my feeling was that this child probably had a degree of craniocephalic mismatch, and the Chiari didn't look that severe to me, but there was a bit of a dolichoid dens, and I suggested posterior calvaire augmentation. But in fact, my colleagues decided to do a foramen magnum decompression, and following the foramen magnum decompression, sorry, I think my screen, oh, there it is. So these are the first post-op images. You can see an adequate foramen magnum decompression was carried out. And you'd imagine that the situation would get better, but in fact, what happened is there was more tonsillar descent of the cerebellum, sorry, the more, cervicomedullary descent of the cerebellum and tonsils. And in fact, the syrinx only got worse and extended. At the time, there was no scoliosis, but as time went by, the child started to get the Syringomyelia developed all the way to the corners and started developing scoliosis as well. So it was reviewed, further opinions obtained from Dominic Thompson and other colleagues in the country. And the recommendation was that there was still some compression of the foramen of Magendie, that perhaps there may be a veil. A second operation was recommended, and the second operation carried out, but all we could see was further descent of the cerebellum and obliteration of the cisterna magnum. And now, in fact, the tonsils were also resected at the second operation. And what you can see now is that actually the cerebellum is coming down because there's no more bone to stop it. And the syrinx only got worse, and the child became, started becoming clumsy now at this point. You can see how big the syrinx has become. So at this point, they decided to consider the posterior calvaire augmentation, which I carried out. And this is the post-op 3-month image showing a very rapid decompression of the Syringomyelia, clinical improvement in the child. And then I think there's a further, oh, sorry, there's the image is not here, but there's a further image showing that the hindbrain hernia is also regressed now. So I think in all of these cases, particularly if there is a failure, we've published this particular case as well. Subsequently, a second case came to us with a similar failure of improvement following a foramen magnum decompression and following calvaire augmentation, the syrinx deflated and the hindbrain hernia got better. So in those cases where you have had a failure of a primary resolution with the foramen magnum decompression, you can still do a posterior calvary augmentation, which is essentially supratentorial, above the transverse sinus, above the torcular, so it's less dangerous as well, and creates the adequate space for the posterior fossa contents to fall back and allow improvement in CSF flow. So that, I think I just wanted to show that and say that you have multiple options in chronic, in complex Chiaris. One is you treat your ventriculomegaly first. Second is increase the size of the skull, which is extradural, does not involve any risk of postoperative hydrocephalus. And if all of that fails, then you can still consider, in life-critical cases, a foramen magnum decompression to save, a child. But in most cases, our failure rate has been 1 case out of 45 operations now. So I think that, the failure rate is very low. And in small, and I forgot to tell you, but skull-based abnormalities, please, you've got to do a fixation in those cases. And for Syringomyelia, I don't treat the Syringomyelia. Once I treat the Chiari and the or the tethered cord, I've been amazed to see how quickly the syrinx it regresses and deflates. So I think that's the sort of messages from this meeting, was that we should stop calling, Chiari malformation and call it deformation, and certainly consider a calvary augmentation, treat instability and the hydrocephalus.